Hello, my name is Karina Cabrita and I'm a product manager at Cytognos. It is my pleasure to present to you our invited speaker for today's webinar, Tomas Kalina. You will cover the EuroFlow Primary Immunodeficiency panels as a powerful tool for diagnostic patient care. Tomas Kalina currently is an associate professor at the Department of Pediatric Hematology and Oncology at the Charles University in Prague. He is an expert in flow cytometry and he develops research, diagnostic and monitoring techniques for immunodeficiency investigation and hematology. He graduated a medical doctor in 2000 and started his research and diagnostic career in Prague. He then did a postdoctoral fellowship at the Fred Hutchinson Cancer Research Center in Seattle, in the United States, where he worked on the immune reconstitution of post-bone marrow transplant. In 2005, he received his PhD in immunology. He was one of the founding members of the EuroFlow Consortium in 2006 and was responsible for technical issues and developed the EuroFlow Quality Assessment Scheme. He has developed methods for flow cytometry standardization, affinity proteomics, spectral and mass cytometry applications, and data analysis techniques. In 2010, he received the Isaac Scholar Award. He is currently an HCDM Council member and an ESLO board member, and he serves as an associated editor in the Cytometry 8 journal. He has currently published over 90 publications in reference journals. We are very happy to have you here today, Thomas. Thank you and welcome.
Dear colleagues, let me introduce you to the diagnostic flow cytometry panels developed by EuroFlow for the primary immunodeficiency diagnostics. I will first talk about PID and the inherent struggles to properly diagnose patients with PID. I will highlight the role of the flow cytometry in PID diagnostics. I will describe the individual EuroFlow panels and show their power on few selected cases. And at the end, I will conclude with the diagnostic procedures helpful in diagnosing SCID patients in early childhood. So first, this whole talk will talk about defects in the development of lymphocytes. So you all know that lymphocytes are developing from the hematopoietic stem cells, and there is a number of important genes that are involved in the development of lymphocytes, and any of those genes highlighted, but also many more, can be responsible for a defect that leads to the arrest in the development and ensuing immunodeficiency. These different diverse immunodeficiencies are then characterized and structured in the documents prepared by the international community and classified into several types of diseases such as the T-B plus SCID, T-B minus SCID, and so on. This is a publication that is the most recent update on the classification that comes from the IUIS. And in this publication, we can see how dramatically the number of known defects grows all the way, and especially now with the wide usage of the next generation sequencing. And on the second part of the graph, you can see the recent defects that were added between the pre-last version and the last version of the IUIS classification. So essentially, every 2 years, there is a number of new genes that are responsible for PIDs in man. This, however, presents a diagnostic challenge because the different PIDs have a diverse clinical presentation. They may diverge in the way how they are presented in particular patients. NGS is very useful in identifying the gene mutation. So NGS is now widely used and took over some of the diagnostic burden from flow cytometry, and we need to reassess the role of the individual modalities in the diagnostic patient care. and immunophenotyping by flow cytometry remains to be very useful and actually very potent tool that offers a very fast answers to the basic diagnostic questions, especially in the very young patients with a very severe PIDs. The other aspect of the PID diagnostics is that there are diverse diseases that are caused by these individual mutations that have a very different disease severity. There are some, such as the SCID and CID categories that require immediate transplantation. So here time matters, and diagnosis made on time can mean complete different outcome for the patients, as there is many papers describing that patients transplanted without any infectious complications do exceptionally well. There are other defects that are found only later in age, and their clear decision about whether or not to transplant is still lacking a consensus in a field. Still, other diseases profit from administration of targeted inhibitors of a particular signaling pathways. And in one of the biggest groups, such as CVID, the patient care is so far symptomatic by immunoglobulin treatment. So different diseases have a different severity, different time of onset, and also present a different challenge in terms of whether or not diagnosis must be done in days or weeks or years, and how the outcome of patient is changed by the proper diagnosis. When we employ whole exome sequencing in primary immunodeficiencies, we see typically this kind of a picture. This is our cohort here in Prague, and done by Eva Froňková and Michal Svatoň, and pretty much similar graphs would be shown by other groups all over the world. So roughly 1/4 of patients that is sequenced gets a very conclusive result relatively fast. So after the sequencing, we know what kind of gene is affected, and we know what is the diagnosis. There is some proportion of patients that have polymorphic risk alleles that can contribute to a particular disease phenotype, but are not the only and solely responsible gene defects that define this type of a PID. And some proportion, in our cohort, it was 9% of patients, is identified with a new mutation that requires a functional testing so that we can conclude this as a disease-causing mutation. And unfortunately, still about half of the patients would not receive their diagnosis even after whole exome sequencing, for the reason that either it's a complicated molecular biology, or it's an unknown gene, or it's a polymorphic disease, a multigenic disease origin. In those patients, other modalities can be offered with some success, and we will not talk about this during this talk. What is the role of the flow cytometry in PID? So I would argue that the most important role of the flow cytometry is a fast screening, especially fast screening for these very severe conditions like SCID and CID. In essence, this is a missing cell identification. So we are trying to see whether there is all of the lymphocyte subsets that we expect, or any or multiple of them are missing. Another important role is our supporting diagnosis. So in case where there is a gene mutation identified by NGS and we see a particular phenotype, both together can be concluded as a particular disease and diagnosis is made, where our cytometry investigation is only adding to the information that primarily is taken from the NGS investigation. We can, in some cases, make a direct diagnosis by flow, where we identify the missing protein, for instance, in CD27 deficiency, perforin deficiency, HLA-DR deficiency, and others. And we can also provide interesting and important functional readout to the in the testing phase of the new immunodeficiencies with novel mutations. These last 2 points will not be discussed further in my talk. I will focus only on the first two objectives because these are covered by the standardized EuroFlow PID tubes. What is the challenge with PID? So the PID is a rare disease diagnostic problem. So most of us will never see those patients frequently. So it's very difficult to communicate the knowledge and to somehow be sure about one's memory in diagnosing those cases, because individual defects will vary. And even if you see a bunch of different PIDs, you might not see some of them repeatedly. Frequently, they would actually be non-typical. So you would always expect there is a particular presentation or immunophenotype of the defect, but somewhere in the literature, you will always find that there are also non-typical cases, and it might well happen that your first case will be non-typical. We don't fully understand some of them. Some of them we do. Diagnostic criteria are in development, so we might not find the unique criteria that are complete to make our diagnosis. We need to employ this approach that I can call diagnosis by research. And one of the big issues is, how do we share the knowledge? How can my experience help you? How can your experience help me? So with this in mind, we have established a work package among the EuroFlow labs that are typically taking care of a PID in the centralized diagnostic setup. So these are typically centers that receive cases from bigger regions. We established an interlaboratory collaboration with a full standardization. And then we aim to develop a computer-assisted data analysis. The approach we developed is a two-step approach. So first, we have a PID orientation tube, and here is an algorithm of the investigation. So the PI.tube tube is a tube that is investigated first, and if there is a T-cell defect, we can follow up with one of these T-cell oriented tube. If there is a B-cell defect, we can follow up with several of these B-cell oriented tubes. However, if there is a strong suspicion in children below 1 year, we can do upfront both SCID RTE tube and the PI.tube tube. So the PI.tube tube is essentially similar to the TBMK test that you are all familiar with. However, it is supplemented with 4 more reagents that allow us to also evaluate the naive effector memory phenotype of the T cells, and also it allows us to evaluate a B cell phenotype in more detail. This is a gating of the individual subsets with a PI.tube tube. We can identify 18 unique populations of lymphocytes with this tube. And when we evaluate a normal healthy individual, we should see the T cells, alpha, beta, and gamma delta, B cells, NK cells, and among T cells, the naive and effector and memory stages of CD8 and naive memory and effector stages of CD4, double negative T cells, and also naive, unswitched, and switched memory and plasma cells in the B cell compartment. Together with the development of this tube, we have also acquired reference values on a healthy volunteers of different age groups. And as you can see in this graph, the lymphocyte compartment is actually pretty different in the different age groups. So it is well known that especially in the first 2 years of life, the changes in this compartment are very dynamic in alignment with the aim of the immune system to prepare the individual for later life and to be able to face all these new infections that are surrounding us in our environment. And as a newborns and toddlers, we have to deal with most of them for the first time. Also, with the spider tube, we have developed an approach how to evaluate the measure tube by computer-assisted way. So we have based our evaluation on the populations in the database of normal cells, and then the algorithm can show us only those cells that are somewhat unexpected, that were not matched with cells in a database, and these can be evaluated by the user so that we have a full control over what is happening in this evaluation. And at the end, a report is created already comparing the data analyzed in this sample with the database of reference values. This is my only commercial slide in this presentation, and this is all work done by Cytognos and their experts with the data acquired in the EuroFlow labs. Now back to the EuroFlow algorithm. So as I said before, we have some a priori situations that either show a high suspicion of SCID or CID. In this case, we do SCID-RT tube together with the PIDO tube, or the original setup is not so suspicious of PID, so we want to do only PIDO tube, and only if a abnormality is found, we follow up with T or B cell investigation. If we already have a high pretest suspicion of primary antibody deficiency, we can perform the PIDO together with the B cell tubes right from the beginning. And this is all dependent on your particular group of patients that you typically receive, on your other modalities that you use for diagnostics and the local arrangements. And this approach is relatively flexible, so you can decide to either maximize yield by measuring these tubes together, or you can minimize the cost by going step by step. This is an example of a data that you can see from the PIDO tube again. Normal healthy individual is shown here, overlapping different individuals and showing that the individuals actually match exactly the same phenotype. So this is the result of the standardized cytometer setup and the standardized sample preparation protocol. Healthy donor has all the subsets that you would expect. And in contrast to that, patient with, for instance, STAT3 gain-of-function mutation is lacking here the switched memory B cells. Patient with a SCID caused by the REC2 mutation will have, in concordance with the literature, absence of the B cells and both types of T cells, while the NK cells would be still present. So here the diagnosis is made already. And if we want to evaluate further the STAT3 patients, we can decide to go to the pre-GC2 based on this abnormality, or we can also include the evaluation of the T-cell subsets by a T-cell subset tube. Another example showing now that we can actually evaluate even patients with a change in the distribution of subsets and individual subset or within subsets abnormalities. This is a patient with APDS caused by the PI3 kinase activating mutation. What you see is that you are completely missing the switched memory B cells. If you compare it to the H values, reference values, you see that there is also a decrease in of the pre-GC compartment. However, they are not missing completely, and all the memory B cells are decreased compared to the reference values. You would also see quite characteristic redistribution between naive and central memory CD8 T cells, where naive are decreased while the central memory are increased, in fact. Patients with GATA2 mutation will have fewer B cells, mostly owing to the fewer pre-GC cells, and the switched and unswitched memory B cells can be present even in a normal numbers. There will also be some decrease in CD4 T cells. So again, you might decide to investigate further the pre-GC tube or the T cell subset tube. However, when we analyze all this cohort, we realize there is too much of a too complex data. And the critical information we would like to see is whether there are particular hallmarks that can point us to a given PID, something like a biomarker subsets. So we investigate a cohort of nearly 100 PIDs with defined molecular lesion in 6 EuroFlow labs with the 8-color standardized cytometry. And then we try to evaluate the difference in those patients compared to the age-matched reference healthy donors. So now if I would show you this data, anything that gets very red has decreased values below 5 standard deviations. If it's very green, it's values greater than 5 standard deviations above the reference. And if this feature is found in more than 3/4 of the patients, it will be dark gray. And if it's only between half and 3/4 of the patients, it will be in a light gray. If it's in white, it's below 50%. Now we can see that patients with mutations in RAC1, RAC2, or Artemis are in fact lacking the lymphocytes, have redistribution towards the NK cells in relative numbers because they are missing essentially all the T cells and here, and also the B cells. However, the B cells have a relatively variable presentation in normal, so this would not be captured by these relatively broad reference values. However, there are patients that have T cells even in the presence of mutations in RAC1 gene. This is a so-called Alps Syndrome. Or there are other patients with any SCID diagnosed that can present with T cells in case of maternal engraftment. So these are the two cases where you see that in one of them there is nothing but NK cells, but in the other one, a lot of the other B cells and T cells are present, but what you do see is that you are lacking the naive forms of the T cells. So naive CD8 and naive CD4 are actually very strong hallmarks of a PID. So if those are decreased or absent, this is very likely that this is a PID. We can then make such a big table of all the hallmarks where all the subsets are in the individual rows and all the groups of diseases are as columns. And this will show us what type of individual defects or repeated defects we can find in particular groups of patients. So quite unsurprising is the fact that patients with complement deficiencies don't show any abnormalities in the lymphocyte compartment. Patients with ZAP7 deficiency show that they are mostly having problems with T cells. The biggest are the naive CD8 and naive CD4. They have a redistribution in CD4 towards the effector stages. So that's why in the evaluation of the complete amounts of CD4, they don't show abnormalities and they only show decreased CD8 total cells. Patients with a BTK mutation that leads to the Bruton agammaglobulinemia show defects in B cells. Basically, since they are completely missing all the stages, all of the subsets are missing. Patients with Alps syndrome that is typically caused by the improper FAS control of the double negative T cells, as expected, show abnormally high numbers of double negative T cells. And patients with GATA2 deficiency show multiple defects of the B cell and also T cell compartment. The deeper evaluation of the B cells can be done using one of the B cell oriented tubes. In this case, I'm showing you a pre-GC tube. So this is evaluating the B cells that has not reached the germinal central yet. So there are markers looking at the transitional B cells, IgM, IgD, memory marker CD27, and an interesting marker CD21 that can show some particular abnormalities in CVID patients. So you can see that in CVID, the memory compartment can be empty, and in the agammaglobulinemia, basically all the compartment is empty. Now we can move towards the severe combined immunodeficiency. So in healthy individuals, we see with the SCID RTE tube of EuroFlow a presence of T cells that are either gamma delta negative, so presumably alpha beta, gamma delta positive T cells, and also CD19 B cells. In cases where we are missing completely the CD3 compartment, the diagnosis of SCID is not difficult, it's obvious. However, there can be patients like this one where T cells are decreased, but still are present in a considerable numbers, 42% of lymphocytes. So we can say that while we all understand that the SCID is accompanied by the absence of T cells, we should acknowledge that also in many SCIDs, T cells are present, but they might be non-functional or malfunctional. So these T cells can actually lead to dysregulation and signs of immunopathology in those patients. Why these cells are present in some of the patients with SCID? So either because it's an oligoclonal expansion in the hypomorphic mutations, RAGs, or kind of a leaky SCID, or it can be T cells of maternal T cell engraftment in any SCID. The PIDO tube in the SCID would show essentially either complete absence or different phenotypes. Again, of note is that while newborn has his T cells mostly of naive phenotype, in all the immunodeficiencies leading to SCID, we see complete absence of the naive T cells. The second tube we want to employ in these patients in case there are some T cells present, such as in those BCD in this example. We recommend to continue with a SCID RTE tube measurement. And in those patients, the SCID RTE tube would show that there would be a lack of naive forms because all the T cells present are generated by peripheral expansion. Those cells are activated, and there is a complete lack of recent thymic emigrants because there is no thymic output. This is a healthy newborn. These are the subsets that we want to see, that these are present, these are absent, and these are present. So RT is activated naive. SCID RTE tube is using markers to gate gamma delta CD3, CD8, and CD4, and then is supplemented by markers used to define a naive phenotype, activation, and recent thymic emigrants. So how these two tubes complement? So by purpose, these two tubes use different markers to identify naive T cells. So PyDot uses 27 and 45 RA to define naive, while SCID RTE tube uses combination of the other isoforms, CD45, CD45RO, and CD62L to define naive. SCID RTE tube can add also the HLA-DR into the evaluation so that we can have a cleaner view on the naive T cells that are by definition not activated. And this is a picture that we would see in a SCID with maternal engraftment that is completely lacking the naive T cells by both tubes. If you would ask me whether PyDot is a good enough screening for the absence of naive T cells, I would argue with this picture where you see that the correlation between the naive T cell definition by PyDot tube and SCID RTE tube is actually very good. So PyDot is in fact a very good screening for the absence of naive T cells, and SCID RTE tube is a strong confirmation by different combination of antibodies of the same fact. So we gate HLA-DR negative cells in order to reach the naive compartment, and then from this gate we establish the frequency of recent thymic emigrants. With a SCID with maternal engraftment, this is really a 0. In the same time, in these patients, we see there is a massive activation by HLA-DR and absence of the naive T cells. If we put together all the patients we investigated, you can see that although there is definitely a decrease of T cells in both the SCID patients and the other immunodeficiencies diagnosed in patients below 2 years of age, there is also the most striking difference can be observed in the RTE, where there is a complete absence and a significant decrease in the RTEs in most of the patients that we had in our cohort. And we can say that there is a sensitivity of 100% to detect SCID when we use the RTEs as a readout, and a sensitivity of 91% if we use RTE to detect the other PIDs. However, the remaining patient that was not detected by the absence of RTE was detected by the presence of the double negative T cells, since it was a Alps patient. So in summary, I would argue that the PyDot tube is able to disclose biomarker subsets in all lymphoid PIDs. Most frequently, it is a lack of naive T cells. SCID RTE tube will be able to further disclose recent thymic emigrants, naive and activated subsets of T cells, and provides 100% test sensitivity for SCID, even for the variants with presence of T cells such as Alps Syndrome and maternal engraftment. Pre-GC tube discloses disordered B cells in CVID, agammaglobulinemia, but also in the activated PI3 kinase syndrome. And all EuroFlow tubes perform reliably in interlaboratory setting. And on top of that, PyDot tube has a database-driven automated gating in Finicid, facilitating the identification of individual subsets and offering the possibility to compare against the database of reference values of normal, healthy individuals of different age groups. In summary, the investigation chart suggested by EuroFlow follows from one of the entry conditions, starts with the PID orientation tube always. If there is any sort of a problem, like T cells are missing or are below 5th percentile, we would investigate further in younger patients with suspicion to SCID. We would use the SCID-RT tube. With the older patients, we would use the T cell subset tube that can show well the redistribution between different subsets. In B cell deficiencies, we would investigate pre-GC and post-GC B cells. We can investigate isotypes expressed on a different B cells, which is at the moment more research type of a question. And we can also investigate the development of the B cells in the bone marrow by the BCP tube. So what is the role of flow cytometry in the world of NGS? So after reassessing the contributions of the individual diagnostic modalities, I would argue that flow cytometry can provide fast and simple lymphocyte screening and indicate patients in a very fast manner for the NGS investigation, and thus facilitate the diagnosis in patients with SCID and CID. RTE detection would provide very strong criteria for diagnosis of SCID. The phenotyping with naive gamma delta and HLA-DR that is present in the SCID RTE tube can allow also for the CID diagnosis in the absence of molecular lesion. So even if NGS would not detect any lesion, the acid criteria for CID can be drawn from the combination of PDOT and SCID RTE tube, and these patients can be directed for bone marrow transplantation. In other cases, we can use the flow cytometry to further understand the biology, describe new PIDs, and we can also use flow cytometry to monitor the targeted therapies. And in this case, we would run the complete EuroFlow panels. And we could also use flow cytometry to detect the affected proteins, such as the deficiency of CD27, HLA-DR, or others. Only some of them can be detected directly from the PyDOT and SCID RTE tubes. The other proteins are detectable by cytometry, but we would have to assemble ad hoc tubes for their detection. And in this case, we can establish PID diagnosis right away from the flow cytometry investigation. All these initial tests are tests that can be deployed in local centers with relatively low complexity and relatively low cost. The other tests can be restricted to the centralized labs where there is a room and a need to investigate further the unclear and new immunodeficiencies. These direct detections of proteins need to be used in centers that specialize on particular disease groups, because it's not feasible to be stocked with all possible proteins that can be absent in those patients. So this is either run in populations where there is a higher incidence of those PIDs, or in centers that couple research investigations to the PID diagnostics. Finally, I would offer you a few tips if you are a clinician, how to successfully collaborate with a flow lab. I think it's very important that you specify well what do you need, what do you suspect, and ideally if you call a flow lab to discuss what is strange about this patient so that we can prepare for this patient well and we can choose the right test. So this fact is now easier with the EuroFlow panels because even if we use the two-step procedure, we will eventually get to the full evaluation of all the abnormal B or T cells in these patients, but still it's better if you talk to us. Send us a fresh sample. Avoid Friday afternoon draws that are difficult to finish off in the working hours. And we need a fresh sample. So I would say no more than 24 hours old. And we might need to draw additional blood and do additional tests next day, especially in those cases that are untypical and that would need to or require some more research type of tests. If possible, you should centralize diagnostics of PID and distribute the tasks so that labs that are close to the patients are running the screenings that can be done fast, and labs that are equipped with NGS and can perform some of the research tests have available all these samples available for further and more detailed evaluation. Also, it is important that it's not only about making the right test, but it's frequently also about having the right normal values, which are difficult to obtain and definitely impossible to obtain for all possible tests that can be done. And just talk to us. We are here to talk to you. And with that, I would like to acknowledge all my colleagues from the Childhood Leukemia Investigation Prague group that contributed to the PID efforts of EuroFlow, our colleagues from the Department of Immunology and Department of Pediatrics, and colleagues from the EuroFlow labs, especially Miriam van den Burg, Jacques van Dongen, Martin Perez, Andres, and Alberto Orfao. Thank you very much for your attention, and I'm happy to take any questions here.